Good morning, everyone. For those who are returning, welcome back. And for those who are just joining, good morning to the Racism and Its Implications in Clinical Research workshop. My name is Melita Terry, and I am the Community Engagement Coordinator at the University of Pittsburgh Alzheimer's Disease Research Center. We will now begin our session one with one of our other planning committee members, Dr. Beth Shaban, who will be introducing our featured speakers. Beth Shaban is a new faculty in epidemiology at the University of Pittsburgh Graduate School of Public Health and a University of Pittsburgh Alzheimer's Disease Research Center REC scholar working with the Outreach Recruitment and Engagement, or CORE. She integrates epidemiology, biostatistics, neuroscience imaging, and neuroimaging, and psychology to study vascular contributions to cognitive impairment and dementia, including Alzheimer's disease, using a population neuroscience framework. Beth, I'm more than happy to give the rein to you to introduce our featured speakers and to give a little more insight on our session one. Thank you very much.
Thank you so much, Melita. And welcome back to people who are returning, and welcome for the first time for those of you who are just joining us. For this session, I'm really excited that we're going to hear from three speakers, Dr. Ashley Hill, Dr. Patricia Documét, and Ms. Uchenna Mbawuike. And so first, I'm going to begin by giving their introductions, and then we'll start off by hearing their presentations and open up for an interactive Q&A session. So it's my pleasure to introduce Dr. Ashley Hill. Dr. Hill is also new faculty in the Department of Epidemiology. She's an assistant professor, and she's a reproductive epidemiologist. Her research aims to reduce disparities in sexually transmitted infections and reproductive sequelae for young people. Specifically, she aims to include social and structural determinants of adverse sexual and reproductive outcomes in her research. Her research agenda integrates epidemiologic study design, intervention development, and community partnered research to address the sexually transmitted infection burden in adolescents and young adults. And in addition to her primary research program, what's really important for you to know and what she'll be speaking about today is that she has epidemiologic field experience with contact tracing and disease intervention. She's currently providing support for COVID-19 response efforts in both Allegheny County, Pennsylvania, and throughout the state of Georgia. Next up, I want to introduce Dr. Patricia Documét. Dr. Documét is Associate Professor of Behavioral and Community Health Sciences at the University of Pittsburgh Graduate School of Public Health, and she serves as Director of Latinx Research and Outreach at the Center for Health Equity. She was originally trained as a pediatrician and has 23 years of experience working with emerging Latinx communities, including evaluation, mixed methods, and participatory studies with community health workers. Most of her research has been with Spanish speakers, and she's extensively involved with the local Pittsburgh Latinx community, currently serving as board president for Casa San Jose, a welcome center for Latinx people in the Pittsburgh area. And finally, Ms. Uchenna Mbawuike is a research specialist at the University of Pittsburgh School of Nursing and a Master's of Public Policy and Management candidate at Pittsburgh's Graduate School of Public and International Affairs, or GISPIA. Ms. Mbawuike's capstone focus is on equitable and ethical approaches to offers of payments made to research participants, particularly research participants of color. More specifically, she has worked to simplify and demystify human participant research regulatory guidance through clear graphic decisional charts that both institutional review boards and researchers can use. Outside of her graduate school and professional work, which I'm sure keeps her incredibly busy, she is also a student leader, serving as a board member for multiple GISPIA committees. She was recently awarded the Inclusion Award for Community Building by the Association of Professional Schools of International Affairs. And she also serves as a community advocate in her role on the Community Research Advisory Board through the Center for Health Equity at Pitt's Graduate School of Public Health. So it's my pleasure to turn things over now for the first presentation by Dr. Ashley Hill. Dr. Hill?
Hi, good morning. Thanks, Beth. And I'm going to share my screen. I have to say that being the first presenter after Dr. Thomas is certainly a little bit overwhelming, but I was very energized, just as everyone else has been saying in the chat, by that presentation. And I think most notably struck by the importance that our historical context of being faculty at the University of Pittsburgh, and particularly in the Graduate School of Public Health, how important it is for us to understand the people who've come before us and have made notable strides to even allow, my presence to be there. So I have to say thank you and truly appreciate being in this space today. So I'm going to talk to you a little bit about some of the work that I've been doing with our community collaborators, as well as some of my colleagues at the University of Pittsburgh around inequities in COVID vaccine uptake and access. Just a little bit about me, as Beth said, and I appreciate again that my primary research is focused on reproductive epidemiology and again, really situated in this space of understanding the trajectories and the social determinants of sexually transmitted infections and outcomes related to those when left untreated or otherwise. And so I think that what really brought me to this space is opportunities to have that field experience and working in local public health, specifically around STD and HIV prevention and surveillance. In several opportunities that I've had to do disease investigation on the ground through contact tracing for several specific health events that we've had over the past few years. And so that's what really, I think, situated me in this space to be able to think about COVID in the context of social determinants of health and think about COVID in ways that we can really promote health equity. And so just to acknowledge some of our funding, we applied for and received a small grant from the University of Pittsburgh Clinical and Translational Sciences Institute to specifically look at some of these inequities across the county. And we've also partnered with the REACH project through their supplement funded through the CDC and Adagio Health to really examine some of the, again, contextual factors. So to begin, I just kind of want to set the stage of what the landscape of COVID-19 looks like in the county. And so this data are recent through mid-September. And we see that for the predominant timeline of our experiences with the pandemic in Allegheny County, cases have been disproportionately impacting Black individuals. And that's denoted here by this green bar. And so across the context of both infections and hospitalizations, we also see that overwhelmingly our Black population in the county are bearing the disproportionate burden of COVID-19 and its impacts. We did see earlier on in the pandemic that there was a larger gap between deaths related to COVID-19 for Black individuals, and while that gap has decreased quite a bit, we are still seeing unfortunate trajectories in COVID-19 deaths. And so really, I think what has driven a lot of the work here is we're asking the question, why? Why are we seeing these disparities, and what are some of the things that we can do to really start to address and promote more equitable systems, particularly around COVID-19, but also broadly once the pandemic is over. And I think it's important to see and think about the context of vaccinations. Obviously, we now have a very effective mitigation effort, but we're having some issues with uptake, I think, across the United States, but more specifically in our state and also in this specific region. And so while we're ranked about 6th in the state for vaccinations, we are seeing that there are still quite stark disparities in uptake for Black-white particular comparisons. And so we see that roughly 57% of white individuals in the county are fully vaccinated versus 38%. And so again, sort of asking that question of why. And I think, Dr. Thomas really set the stage for understanding what some of the factors related to that why are, because we have a significant impacts on our social determinants. And so thinking about what social determinants are, they really are the factors that drive and influence population health and individual health, but have very little to do with an individual's decision making. And so they may have an impact from workplace interactions. They may have impacts from where an individual lives and how many people live around them. And then there may be some internal or individual contextual factors, such as behaviors or chronic disease, that also influence the risk of specific outcomes. And so thinking about this in the context, again, of the COVID-19 pandemic has been really important for us, especially understanding that there are racial disparities. And so again, asking that question of why are we seeing these particularly stark racial and ethnic disparities? And so we see, particularly in this figure, that we understand certain individual level characteristics, certain system level and population level characteristics, and then also some healthcare related characteristics that can certainly influence, and we have come to understand are significant drivers of some of these disparities. So for instance, at the individual level, we see that frontline workers and individuals who had to consistently go to work, even though we were under stay-at-home orders or there were advisements to not be in heavily populated areas, many people did not have the choice to not engage and not be in areas where high transmission were occurring. And so we recognize that those are some of the factors that increase the risk and exposure to COVID. We also saw, as has been mentioned before in the previous presentation, that there's quite a bit of distrust in the healthcare system, as well as some of the therapeutics that are developed, and people have a lot of questions. And I think it's important, I certainly encourage my family and the people who are in my life to ask lots of questions. So it's important for us to think about how to critically answer those questions and be thoughtful about engaging with our communities to understand how we're developing these therapeutics and why they're effective. And also thinking about answering and acknowledging some of the issues that are raised by communities. And then I think lastly, in this particular figure, we see that there is some access and specific engagement issues. And so we see that there can be issues of access as far as being able to actually obtain that care, even when it is desired, and expectations of being treated fairly, as we talked about again before with our example of Dr. Susan Moore and how her treatment was not fair, and she was not able to be heard and listened to, and ultimately had a negative outcome. And so it's important for us to recognize, to name those things, and then to also begin to address them. And I think lastly, in this conversation about COVID-19, it's really important for us to think a little bit about this idea of vaccine hesitancy. And while I don't think that it is the answer, I do think that there are very real reasons why people may be hesitant. And so, again, in thinking about the historical context of how public health and medicine has engaged with communities, people may have very real questions and may have very real concerns that have consistently and continuously gone addressed over the course of this pandemic. And so we really have to think about, when we kind of have these conversations about hesitancy, are we asking the reasons why? And are we truly addressing people's needs as well as addressing their concerns? And so I like to include some of these slides. And again, I'm so encouraged to be able to follow, a presentation that was so rich with history. And also, have to make a note to Paula Davis that I think we should probably have some things like this incorporated, particularly related to the historical context of Pitt and how, the things that have gone on in the city of Pittsburgh, for those of us who are not from Pittsburgh, for us to really understand that context. But as a reproductive health researcher and an individual, I think myself, who's very interested in history, I've recognized how important it is for us to understand the historical context of the perspectives that people have developed. And so I like to include this particular headline because I think it's really important for sexual and reproductive health. because this individual who, again, there were statues erected of James Sims across the United States. And he was touted as the father of modern gynecology, served as the president of both the American Medical Association and the American Gynecological Association at the time, but really claimed to fame in his ability to develop the notoriety that he had was because he performed experiments on slaves, because he performed these experiments with no anesthesia and really under extremely inhumane circumstances. And again, these are things, procedures, technologies that we still use today. And so I think it's important, again, for us to think about the context of these intergenerational traumas, to think about the context of how people are what they're coming to us with when, if we are physicians or if we are clinical researchers, how their histories and their lives have shaped narratives that they bring with them that are very true. And so it's very important for us, again, I think, to understand our historical context for the fields that we're in, for the questions that we're trying to answer, and to really address those in the work that we're doing. And again, we've already kind of discussed this, but I think as a sexual health researcher, it's vitally important for me, again, to understand not only the position and the space that I occupy physically as a Pitt Public Health faculty, but also how these sorts of experiments and these, again, intergenerational traumas not only have had a significant impact on disease morbidity and transmission, particularly in the Southern United States, but also how it may impact individuals' trustworthiness to engage and even answer questions when it comes to their sexual and reproductive health. And finally, these ideas of reproductive injustice that have not only been broadly implicated in United States history, but continue to be issues that we see today, such as forced sterilizations and hysterectomies that, again, we've had a very long and sordid history with these types of atrocities. And this image is of Fannie Lou Hamer, who really was a civil rights activist in her own right, but had a very public discussion about her own forced hysterectomy, and really became one of the central advocate for reproductive justice and reproductive rights in the United States. And so I recognize that, being someone who had little information about her brush with reproductive injustice and her experience there, but really seeing it as important, and being able to show the parallels between things that have happened years ago, but that are still happening today. And finally, I also like to show this figure, and again, recognizing that these things are not specific to COVID-19, but are specific to infectious diseases, that Cynthia Prather and colleagues were able to demonstrate this timeline that I think is so powerful to think about in the context of racism and reproductive health, and how there's been actually so little time since people of color, particularly Black people, but also Indigenous individuals, have had basic human rights in the United States, and have been subjected to, so many atrocities in the name of science, so many atrocities in the name of the development and the progression of our research field, that we really have to think about how that impacts and shapes even the young people that we see today. Again, the stories that they're told, the warnings that they receive about going to, the doctor, about engaging in research, about the things that they take. And so it's really important for us to think about this context and how it's not only imperative for us to address it, but also to start to think about how to deconstruct some of the systems that have continued to perpetuate these actions today. And so finally, I think some of the frameworks that I've started to incorporate into my own work are really frameworks that deconstruct race as an exposure for disease, but start to highlight racism in the experiences that society impose on individuals because of their race, as the direct exposure that can be related to an outcome in disease. And so I think that Chandra Ford and Colin Zarambua do an excellent job in really showing us how we have to center both the individual's environment and their population and social characteristics, removing race as that predisposing factor, but really seeing the treatment as the issue and the thing that we have to start to think about measuring. And being able to do that in the context of contextualizing both social conditions and social treatment as diseases, how they can operate, how it can spread, how it can cluster in specific areas, and how it can be directly interacting with both the biological, the physical, and the environmental factors for an individual, and how all of those things working together really can enhance both the disease transmission and progression, and how it can be situated in a space that truly exacerbates these outcomes. And so again, I think this figure by Xiao and colleagues, specifically thinking about the context of COVID-19 and the impacts on individuals with HIV, all of these external factors sort of in the outer rings are all things that we have to really think about in the social context of an individual that can then really impact some of these measurable factors. Again, if we're thinking about mental health, if we're thinking about chronic disease and infections, if we're thinking about any of the other things that we want to measure, we have to also understand how they originated and what they've originally come from. So lastly, just to give you a quick overview of our project, we're really looking to identify some of the factors that are contributing to or barriers and facilitators of vaccine uptake and hesitancy among Black individuals. Again, centering individuals and not looking specifically at as race as a predisposing factor, but at looking at race as a predictor of treatment. We really want to know what are some of the experiences that people have had for testing and vaccination. And then we're working with the Western Pennsylvania Regional Data Center to really start to estimate vaccination and testing rates by county and across zip codes over time. So the first part of our project is to really do a survey. We're asking anyone who's Black who lives in Allegheny County and who is at least 18 to give us their thoughts about a few things, and specifically thinking about trust and distrust in the COVID-19 vaccine, their intentions to vaccinate, experiences with testing, whether or not they intend to vaccinate their children, and some of the impacts that COVID has had on them, as well as where they're getting their information from, particularly social media, and then some of their behavioral health habits. And then these are just a few questions, examples that we have in the survey. We ask about reasons to get vaccinated. We ask about, again, trust and distrust, whether or not they feel Black individuals are receiving the same treatment. And we sort of had talked a little bit today about how that is not the case. And then again, thinking about some of the mitigation efforts, masking, and whether or not individuals are able to actually do those things consistently in the spaces that they occupy. So our team is primarily situated in the Graduate School of Public Health, but we've also been very intentional about having community partners, both with the Black Equity Coalition, which many of us are members of, as well as Homewood Children's Village in the REACH project. And so I have my information here as well as our study email, and I will pass on the floor at this point. Thank you so much for your time and attention.
Thank you so much, Dr. Hill. That was an amazing presentation, and we're very excited and interested, some of us talking among the hosts and panelists in the chat about just sort of this continuation of the topic and the treatment of understanding historical context. So thank you so much. And next up, I'm happy to introduce Dr. Patricia Documét. Dr. Documét, take the floor, please.
Hello, and thank you for inviting me. In the process of sharing my screen there and there. That's what I want to share. Wonderful. So today I'm talking about something a bit different, switching populations to the Latinx, specifically Latinx youth. And we call this carrying the weight of the world, because that's something that one of the people we interviewed said. So at first, I need to talk about the population and the setting where we are working, which is Allegheny County. And this is what we are calling an emerging Latino community or an emerging Latinx community. It's also called a non-traditional destination, a new growth community, and it has several names in the literature, but it is growing because there is a tendency for Latinx to move into areas where there have not been many Latinos recent or traditional. These areas, such as Allegheny County, are characterized by a scattered population. And I keep repeating this, we have 130 zip codes in Allegheny County, and only in 18, there are no Latinx. So there are people everywhere. In all of those, there are not that many people. Only in 12, there are more than 500 Latinx identified individuals. And that is people everywhere. That poses several problems. If you are a provider or a researcher, reaching the population is hard. But if you are within the Latinx population, it is really hard to find somebody who looks like you, who speaks like you, who shares your culture. It's also very hard to find information that pertains to you. And this also brings us to a crisis of belonging. People don't know, well, what am I doing here? I'm like a Martian in a group of lots of people that are different from me. The services are unprepared to serve the community. Right now, we have dedicated Latinx organizations, just a few, but some. 23 years ago, when I started doing this work, we did not. We just had a cultural organization, nothing social service prepared. But many, many services that are out there for people are not prepared linguistically or culturally. And we keep hearing that there are no Latinos in Pittsburgh. That's what people say. It's invisible. Even in reports that are put out about discrimination, about equity, oftentimes the Latinx population is lumped with other groups, and then it's not there. You can't see what you don't talk about. The Allegheny County Health Department traditionally has put Black, white, and other, and there is about the negation of existence. Importantly, for this study, 30% of the population is under 18 years of age. I just want to show you some of the demographics for Allegheny County. These are census measures. So as you see, there is an increase in the numbers, 34,325 in census 2020, probably an undercount because there were lots of issues in what people believed and feared about the potential citizenship question. But this is the percent increase. As you can see, it is 80% increase at a time when the population of Allegheny County has increased 2.5%. It's still small, it's 2.37% of the population of the county. It is increasing faster than the services can keep up. But I specifically want to talk about today some work we did, funded by a grant to Dr. David Brent from the National Institute of Mental Health. It's a qualitative study, completely qualitative. And what we did was interviews with social service and healthcare services providers, mental health and physical health, and focus group with parents of Latinx youth and with Latinx youth. The topics were the stressors, the strengths, and the environment that they confronted. And that's when we got a lot of the things about discrimination. So starting with the results of this study, here, social isolation. I have found this in most research studies I've been doing. It's striking to see how the youth said, well, nobody looks like me, nobody is like me. And the providers also said. The quote on top is from a provider who said, here we are without family. If you're lucky, you have some family member here. It's much easier for you. Because that family that's here has time for you, and they guide you. What happens is that the concept of family is includes many, many people. For some people in the United States, it may include 4 or 5 people, and it's a nuclear family. For Latinx, it usually means 37 or 50 people. It includes the cousins, the grandparents, the uncles, the godparents, and the godchildren, whoever. There are lots of people that are that family. And especially for immigrants, they have come here without that family. Some people come by themselves, especially men. But the thing is that there is not an extended family to rely on. And that's your natural social support. And you can see what this father said. He was talking about somebody else that told him, the son told him, it is that it is do not exist here where I am. I do not exist. They don't take me into account. So that this negation of existence is really hard on everybody whose existence is negated. So what do you mean I'm not here? In addition, other things happen when you move from another country in Latin America, where you always said you were from America, because the definition of America is different. It includes the entire continent. And when you are here, they tell you you're not American, and you're not only not taking into account, but you are told you're not what you used to. And you may have heard of some anti-immigrant climate. In the recent years, it became worse, but it has been there for a long time. The first quote is from a youth that told us, I bumped into like houses, like they have signs going like build a wall for Trump. That really kind of gets me scared, because I feel like if they know where I'm living, they would probably like report me or like call ICE or something. There are too many likes there. This is based in reality. In the past years, well, in the many years, there have been deportations. In the past few years, there were deportations that were not necessarily for people who were criminals, but for anybody. And what happened here in our own community is that I knocked at the door and people opened the door because they were not sure it was their right not to open the door. And if they were looking for Juan Perez, yet Juan Perez was not there, they could just take whoever was there. Oh, Jose Lopez, let's take Jose Lopez, because that's just as good as one. One is as good as the other. We can put them in jail and later deport. We've spoken with people who've lost their parents, who've lost their spouse, or their family members to deportations that were like that. ICE showed up at home. And then there's very little you can do for much that you try. And there is bullying. In this example, bullying is high among immigrant kids, says a provider. And the schools don't realize that. There should be something in the curriculum that really helps Black and white students to understand the experience of diversity. It's talking about Latinx diversity. We heard stories of people being told, children being told by other students, your parents are going to be deported, your parents are going to be deported, with a taunting. Or of teachers asking, are your parents going to be deported? Which is very scary for a child. So these children are internalizing that fear. And of course, there is also discrimination in the communities where they live, where they don't find others like them. So moving as to what this means, this is not the discrimination, but what happens within the community. The community is not necessarily knowledgeable about mental health issues, and there is a lot of stigma. Some people don't realize that depression is an actual thing. they think you can be strong and get over all these things. A provider says that they started seeing a girl that has severe anxiety, and the parents did not understand what anxiety was, or why she was even told to come. So the pediatrician referred the child, and the parents said, "What? Why?" And then there is a quote from a parent that said, "You either have to be stronger or you are picked up on society. So you have to be strong, and that solves your mental health issue." And that's the provider says similar. The dads think that if we are, the psychologist is for the crazy and we are not crazy. Therefore, it's problematic because the parents, not always, but often, do not believe that there is a problem with mental health. And what happens to these kids is that they are carrying the weight of the world, which is the title of these. It happens that they have very inappropriate for their age responsibilities. It turns out that they have to do things that other kids don't have to do. For example, they work not for pocket money, but they work to help their house. As an example, a couple of the youth that were in a focus group, they were working in construction during the weekends to help the family. These are people under 18. This must have been 14 or 15, these two kids. And that's a hard thing to do. In addition, they have to do a lot of chores. My children also did chores at home. They set the table, they took out the trash. But in this case, they have to be at home, basically parenting. The parents work 10 hours a week, often 6 days, 10 hours a day, often 6 days a week. And the children, the youth, have to take care of the little brothers and sisters. They have to cook and feed them, put them to bed. They have to take care of everything in the house, basically parent, until the parents come back. In addition, they tend to be the only ones who speak English well, and that they need to navigate their parents. Increasingly, health services have places for have interpreters or interpretation lines. However, not everything has it, and the children end up interpreting or guiding parents to fill out forms that are not necessarily for them to see, legal forms or health forms that they have to work with. So you see here there is a quote from a youth. I feel I always have to act a certain way, show people that like not all Latino people are the stereotypes that they know, like lazy or don't work or aren't educated. So I feel I have to show them that's not true. And that comes from the parents also feeling this way. Latinx are considered here the worst. They are bad, they are lazy, all those stereotypes. The parents want to show the community that that's not true. One way to show is to tell their kids, you have to be excellent in school and have to be very well behaved. Don't get into trouble. So the kids have also this responsibility to be perfect. And down there is a mother expressing one of those things. I don't want them to speak English only. They want them to keep their Spanish. So in addition to be perfect and translate and cook and work, they have to keep their culture and their language. That's a lot of work. And what happens is that sometimes, well, the kids react by not disclosing their problems to their family. They hold in, they keep secret their issues because they don't want to worry their parents. They think their parents already have enough. In addition, if they tell their parents what the problem is, perhaps the parents are going to say, well, just be strong. If that doesn't happen, they still may not have health insurance or how to pay for mental health care. And if they have that, they may not have the proper transportation. So there are lots of problems about getting to care.
Dr. Documét,
Sometimes, yes.
I apologize for interrupting. Just want to do a little time check. If you can.
I'm almost done. Let me finish
perfect.
it soon. So
Thank you.
then some resort to cutting, and we heard from providers that some people resort to attempting suicide. So what are we doing? We piloted something to help youth deal with these anxieties. And right now we are co-creating it with a youth group called FLY. That's a youth group. And just to finish, I want to say that we need to keep the big picture in mind and listen to the community in all the research we do, but that research is not enough. We have to be in the community, enjoy with them, be part of them, and also advocate for the community. In this case, it's for rights for immigrants. Thank you.
Thank you so much. Apologies for interrupting. I want to make sure that we get time for our very important Q&A. So next we will go to Ms. Uchenna Mbawuike, and we look forward to hearing your presentation, Uchenna.
Thank you so much, Beth. And thank you guys for inviting me to this very wonderful workshop. Melita, shout out to you for doing your thing. This has just been, it's such an honor to be a part of this great panelist. Let me get started. So as Beth said, my name is Uchenna Mbawuike, and I'm excited to talk to you guys about a personal passion project of mine, which is the title of this talk, Equitable and Ethical Offers of Payment to Human Research Subjects, a call to action to IRBs and researchers. So I'm gonna just get started here and summarize everything that I'll be talking about for this talk. So really the main issue is, how much do you pay people to undergo research procedures within a research study? And so from the perspective of people who are human regulatory research subjects, agencies and institutions like IRBs and researchers, the biggest concern is making sure that offers of payments are not so high as to unduly influence or coerce research participation. And I actually want to take the time to define these terms because unfortunately they are used interchangeably. So when you unduly influence research participation, you are offering such a high amount of money, an excessive amount of money, or an appropriate award to obtain compliance. So from the perspective of a research participant, I am willing unreasonably and irrationally against my personal or self-defined interests and values to participate in your research study because you're offering me something that is just too hard to resist. It's just so much money. Why would I say no to that? And then on the other hand, when you coerce research participation, you are forcing compliance, meaning I am going to threaten your livelihood and well-being to force your compliance to participate in my research study. And so the little historically that's been published on this, what we've been seeing are these practices of what is called pay conservatism. And so pay conservatism is offering low amounts of money as a preventative measure to mitigate these issues of undue influence, which is going to be the main focus. Coercion, again, is threatening someone's livelihood so you can force their compliance. And the only time coercion can be a concern is if you threaten to withhold payment that you promise. That's coercion. But again, the main issue at hand is undue influence. And so with pay conservatism, to mitigate that, what you'll see is these offers of low payments. And so the problem that I and other people who study this work argue is that this is exploitive of research participants, because in the context of a research study, the money that you're offering is not commensurate to the value of the contributions that you bring to a research study, including the time that you're sacrificing, the burdens that you're undergoing to participate in these research procedures, the risk exposures that you're also going, the opportunity costs, or whatever other options that you're foregoing to participate in this study. You're being exploited. You're taking on an unfair share of burdens in your transaction to this research study. And so I argue that a better suggested approach, instead of doing this pay conservatism route, is to use decisional charts for pay guidance to take into account some of these factors that research participants have to think about when they're going into a research study. And so I want to go into some important vocabulary and terminology that will help to sort of really address this main issue at hand. How much do we pay people when it comes to their willingness to participate in a research study? So offers of payment come in three different categories. And again, this is something that's used interchangeably, but it's very important to understand that there are three different things: reimbursement, compensation, and incentives. So reimbursement is meant to refund reasonable costs. So like travel, meals, babysitting, whatever costs you're incurring so that you can go and participate in a research study. That is what reimbursement is. Compensation is meant to acknowledge the value of the contributions a research participant brings, including and also acknowledging that the burdens that they're undergoing to participate in these research procedures within a research study. And then incentives aim to increase recruitment. They make the research study more attractive, especially if research participants have another option. So it's something I would say is a little bit more optional, because especially for more burdensome procedures, incentives can be a key way to kind of engage people and get them interested in your research study. And so one thing I'll argue is that in order to be equitable and ethical, reimbursement and compensation should be an ethical expectation, a default. You should always be reimbursing and compensating your participants. And I'll go into the specifics of that momentarily. So I want to talk a little bit about background as far as what are the practices that we know of when it comes to research participant payments from the perspective of institutional review boards, or institutions that review human research subjects studies. So federal policies that there are under the guidance is really emphasizing that, like the common rule and even the Belmont principles, which Dr. Thomas alluded to earlier, emphasize mitigating issues of undue influence. And so the problem with this guidance is, well, how much money would be an issue where undue influence is a concern? There's no guidance on that. And so it's really to the discretion of each individual institutional review board to approve research participant payments. And then from the perspective of researchers who are performing these research studies, when it comes to the practices of offers of payment, there is no standard. They come up with their own standards. In fact, when I have conversations with other researchers, it's just from personal experience. Even within the literature, there's really no explanation for why they're giving the certain payments out. And so again, it's really to the discretion of each individual researcher on how much they offer as payments to research participants. And so this brings me to the problem I talked about earlier, pay conservatism, those offers of low amounts to mitigate these issues of undue influence. It's a common practice and it's exploitive. It's common, and again, there's not a lot published specifically on what compensation looks like, but one of the few analyses that did look at over 400 research studies showed that compensation leaned toward the lower end. And this was from all kinds of, it was drug studies, behavioral studies, survey studies, all kinds of studies across the nation were showing that researchers were offering lower amounts of money to their participants. And so this brings me again to the fact that this practice is exploitive, because you're not, what you're paying and what you're offering and the benefits participants are getting are not equating to the burdens of research participation, which I believe is actually contrary to the IRB's mandate, which is to protect and safeguard the well-being of research participants who choose to enter these research studies. And I want to just give you an anecdote of just to put things into context, because I've been loving the stories that our panelists have been doing, including Dr. Thomas. So, just imagine, and this is not something that's too far-fetched, you're a research participant, and there's a research study going on in Oakland. They're offering you $50 an hour for 2 to 3 hours of your time. They're not doing any reimbursement, so they're not going to reimburse you for any travel or any of that thing. And you have a full-time job that's not work from home. I know a lot of us are working from home, but most people don't. So you have a full-time job that's not work from home, and you live in Mount Lebanon, and you share one car with your spouse, and your spouse actually usually drops you off to your job. So you decide, you know what, I want to be altruistic. I want to participate in this research study. Instead of doing that, I'm not going to go to work. My husband's going to have a car today. So I'm going to take a bus from Mount Lebanon to downtown to Oakland to participate in this research study. And if you're taking this bus during the day between waiting for the bus in Mount Lebanon, then that's already a couple of hours of your time. And then you go all the way to Oakland to do this 2 to 3 hour research study, and they only pay you $25 when you're getting paid $30 per hour at your job. This is exploitive. This is exploitive. Which brings me to the next issue, which is that it's contributing to the racial and ethnic disparities we see in research. It's and again, our wonderful presenters today have talked extensively about the challenges of getting racially diverse groups into research studies, between mistrust, valid reasons of mistrust because of histories of abuse and exploitation. Because even when you think about Pittsburgh and sort of the SES factors, the disparities in that, so we know that burdens such as transportation, not having the luxury to just not go to your full-time job, needing a babysitter, all of these things are stacked up against racially minority groups in certain areas, that the thought of going to a voluntary research study, paying me a little bit amount of money, is unreasonable. It's unreasonable. And then you can even, if you put things into context, as a researcher, you want to do what you can to promote your scientific goals, to make sure that your studies that the data and the outcome from your studies are socially valuable, that they're generalizable, that it can be applicable to as many people as possible. How can it be scientifically valid if you don't have a diverse group of people within your research studies? So this brings me to kind of the small step I'm taking in addressing this, which is clear decision charts that IRBs and researchers can use that can serve as practical guidance to support not only ethical, but equitable pay standards of research participant subjects. And so this is based on already all of that regulatory literature that's out there, several reviewed publications. And I want to also say that if you go on HHS's website, the Office of Health and Human Research Subject Protection Office, they have decision charts, but they're static. They're not very interesting. And you have to go through all this bureaucratic sort of policy work to even get through those decision charts. They don't have it specifically when it comes to research participant payments, but on things like, is this a research study, a human subject research study? Is this an exempt study? So I'm sort of using that same framework to do it specifically for payments, but making it more user-friendly. So let's just do a little sample of what I've created. So first of all, let's do a scenario so we can actually put that decision chart to use. Let's say a study is being conducted in a city where the hourly wage rate of an unskilled worker based on the Bureau of Labor Statistics.gov is $15 an hour. And research participants will be asked to make 3 clinic visits lasting 2 to 3 hours each. And the procedures include having height, weight, blood pressure measured, a blood sample taken just like a finger stick, and then doing several lengthy questionnaires and surveys. As a researcher, I propose to pay my research participants $45 per visit, and using a Vincent card, which is just like a payment card where you can reload research payment money to that card, and the participant could then go to an ATM or a bank and take the cash out. So I came up with that $45 by just multiplying the $15 an hour times 3. So I want to know if this is equitable and ethical, what the payment I came up with. So we'll come to my decision chart. And the question here is, are participants compensated enough for research participation without paying them so much that the payment constitutes undue inducement? And I also want to just give this caveat that this decision chart is informing offers of payment standards for healthy adult participants in federally funded studies that are minimal risk. As you can imagine, research studies come in all shapes and form with all kinds of participant populations we want to target. So we're going to start at the baseline, and this is what this decision chart is informing. So you'll come log in, and you'll see this big arrow here that says start here. And the question is, what is the participant payment intended to do? Are you trying to compensate, reimburse, or incentivize? And the nice thing is, if you're not sure what you're trying to do, if you just press these question marks, it gives you an example, or it gives you a nice defined version of what compensation is, what reimbursement is, and what incentives are. So I am planning to compensate my participants financially for the burdens that result from their participation as a cash payment. So we're going to click that. And so then we're going to go down that decision chart. Is there a clear description of what the compensation is and how it will be provided? I did. I gave a clear description of exactly what it is. It's those Vincent cards, $45 per visit. And I said how it's going to be provided. So yes, we'll click that. Do researchers justify the amounts they propose to offer as compensation? I do, but let's say we said no. If I said no, here comes this pop-up telling you why it's important to justify how much money you're giving as compensation. It will help IRB determine if the dollar amounts are acceptable compensation. And also it reminds you that compensation should offset a participant's reasonable opportunity cost for participating. And we also give you a nice benchmark, which is using this local average hourly wage of an unskilled worker based on BLS.gov. So, but again, I did say yes, so we'll continue down this line of logic and click the yes button. Is the compensation commensurate with the time and burdens of research participation? So what if you're not sure? Again, if you click, here's this yellow button for uncertainty. We give you this benchmark that you can use. It's called a working wage model, where you can use that average hourly wage of an unskilled worker based on BLS.gov. And again, if you said no, we just keep reminding you compensation should acknowledge the importance of the participant's contribution to research and the sacrifices associated with participation. This will help with enrollment of research subjects. And so one thing that's nice about this decision chart is that when you're not sure how to, this is language you can use for the IRB when you're wanting to justify how much money that you're giving to your participant. If you're not sure, is this ethical and equitable? This language within these pop-up boxes will help you to craft that language that you can give to the IRB for your protocols.
Uchenna, sorry to interrupt, but 1 minute check.
That's perfect because I'm on my last slide, so perfect. So I want to end with the heart and the spirit of this workshop, racism and research, and talking about fair compensation reparations. And all of the speakers have talked about how marginalized communities, particularly racial, ethnic minorities, have historically been taken advantage of through their involuntary role and unethical research experiments. We talked about Tuskegee, we talked about, there's a whole list of studies out there where stolen biological material from Black and brown bodies and inhumane research experiments have been performed on people. And they have literally been the bedrock of the scientific discoveries that most of us are taking advantage of today. And what's sad is their lack of access to benefits from these health and scientific advances highlights some of these health and economic disparities that we see in people of color. And I believe that fair compensation and research studies is a very, very basic way to start to right the wrongs of the historical mistreatment of people of color. It's not the way, but it's a basic ethical standpoint that we should be doing. So I don't want to end my talk without acknowledging this amazing team of people you see on the screen. Again, shout out to Melita for giving me the space to talk about this important issue. Dr. Lingler for having conversations with me and helping me think through the logic of this. Melissa is the same thing. She's been really a great critical reviewer of this and made these really amazing slides, so good at that. And of course, Lisa Tamers for being a great and supportive team member in all of this. So with that, I'll take questions with the rest of the panelists. Thank you guys so much for the time.
Wonderful, thank you so much. Just a reminder that you can put your questions in the Q&A feature, and we will, please note if you're directing them to a particular speaker or if it could be anyone on the panel. So let me ask at least the first question while everyone else is getting ready. This question came up actually during Dr. Thomas's talk, and I thought it would be appropriate since Ashley and Patricia tend to work with the younger end of the spectrum in terms of age. So I wonder if you can talk about how to engage older teens, young adults in encouraging them to participate in research and encouraging them to take care of their own health. And what do you see specifically in the populations and topics that you're working with?
So I can address Latinx youth, which is what I've been working with. Well, just being there with them, talking with them. And if you engage them in conversation, that's helpful. You can attend events where they are participating. I'm not the only person doing this. For example, Maya Ragavan and Josefina Bañales, they are also working with Latinx youth right now in research and keeping with them. As an example, for the Latinx Connect conference that we just had the 14, 15, and 16 of October, I was working with youth in Casa San Jose flight group so that they would submit an abstract about their identity, the youth identity. And they did. I couldn't attend it because I was presenting at the same time in a different place, but that was good. That was helping them expose, so encouraging them at least to get exposure and speak out. And that's just an example. Many things like that you can do.
And Dr. Hill, do you want to add?
Yeah, absolutely. I totally agree with Patricia. I think that, you know, if you think about the questions that we have as researchers and really think about the things that are important to youth, that makes a very, you know, easy connection, because not only are you able to really kind of attract their support and attract their attention, but you're also really highlighting and prioritizing the things that they're saying that they want and need and that are important to them. And so really, I think one of the things that we've, you know, need to get back to adopting and prioritizing as researchers is the desires of the communities that we're hoping to serve. And youth are no different. They have thoughts, they have feelings, they have emotions. Particularly older teens at this moment are very much interested in justice, in liberation, in these movements that they're taking upon themselves as a society. And so I think it's really important for us not to come with our own questions, but to really show up and ask a lot of their opinions, a lot of the things that they would like to do, and really champion them in their pursuit of their questions and sort of guiding those investigations from their perspectives.
That's great. That's really great feedback. Thanks to both of you. Uchenna, I hope you don't mind. I'm going to throw a couple questions your way. So the first comes from Cecilia Yates, who wants to know, is there a disparity in compensation between various research topics or the type of research participants?
Yeah, that's an excellent question. Unfortunately, there's just so little published on looking at research participant payments in general, but I know the few analysis where people were trying to see if there were differences in how much people were getting paid. It seemed like oncology, just in general, there was more compensation in that sort of topic. But generally speaking, there's just not a lot of information that can really delve into that. And I know that within just March of this year, it's been, I've been really happy to see more research kind of coming out about talking about fair compensation topics. And as you can imagine, with needing to have diverse subjects within COVID-19 vaccine trials, and that being such a big thing. And then as these panelists have mentioned as well, the burden some of the target populations are facing, compensation is one of those things to consider. And so there have been a lot of writers out there and researchers out there calling for researchers to start advertising how much they're paying their participants and to say what the explanation and justification is. Unfortunately, we have a long way to go, but just generally speaking, we just know that oncology, from the little that's published, that's showing payments, that they tend to be higher compared to some of the others.
I would think also maybe an interesting thing to look at would be neuroimaging studies, which is of course my bias in terms of my research focus, but they do tend to pay for scan visits, research visits. There's a comment from Dr. Craig Byers who is saying, well done. And then the second question that I have for you, and I hope I won't make you nervous or make her nervous by mentioning this, but Nina Silverberg is here and she's with NIH. And so she's wondering, she's saying that was a really incredible presentation.
Thank you.
Is the decision tree tool available yet? And if not, when will it be? No, please share the link.
Unfortunately, it's not. And that's something I'm working on right now, but with some funding and time, maybe. But yeah, that is a priority in amidst school and work. So that is something I'm actively working on, and I'm hoping to get some more support to really make it a thing. Absolutely, I appreciate those comments. So
that's wonderful. So maybe some follow-up when it's ready with NIH, and I know we have a few people from CTSI and the Pitt IRB on the meeting too. I think those would be great things to look at in the future when you have it ready. Let's see, Dr. Hill, this is a question from Mario Brown. Considering what Dr. Thomas started us off with in relation to social determinants of health, how do we begin to address the syndemics you mentioned in marginalized communities versus the one disease, one approach model?
Yeah, thank you so much for that question. I think, starting to move away from this individual level view that I think we've as a kind of, field adopted, in saying that, people are in charge of their outcomes, they're in charge of their health, they're in charge of, their social trajectories. And really what we've come to understand, but many researchers have known for a very long time, is that that's not the case. And so in order for us to truly begin to address the multiple social determinants, the social, biological context, and how, those factors interact, we really have to start to measure it. Number one, I think really start to think about how to critically evaluate the social conditions that people live in, and the treatment that they are subjected to in society, and thinking about how to critically evaluate and capture that are going to be the main ways that we move forward. And so, the work that I'm really trying to do is advocate for and push for the use of frameworks like syndemics, which really say that the social context is just as important as the biological context, and that taken together, they are the ways that we can really start to deconstruct some of these disparities. And so I think that that's the best way that we can do it, is using these frameworks and really applying them in our work.
Great, thank you. And Dr. Documét, we have a question for you from Dr. Craig Byers. If using an interpreter for a study, how does the researcher assure that the translation is accurate, both informing the participants, the researcher's ask, and the accurate response of the participant to the researcher?
Right, that's a problem, because you don't ever know if the translation or the interpretation is going to be perfect. It can be rehearsed for the things that are in a questionnaire, but not for the things that come up in our questions. Therefore, what we do is always hire people who can speak the language of the participant. And in that way, you don't have that problem. We have had no problem hiring Spanish speakers. It's harder, and we have to work a bit more to hire people who speak indigenous language. But it's to hire Spanish speakers is really not difficult. So
that's great to know. And I wonder, while we're with you, Dr. Documét, if this is a question that I'm curious about, what's the age distribution of Latinx residents of Allegheny County? Do they tend to skew younger? Are there a lot of older adults?
There are a lot of younger people. As I said, 30% are under 18. That's a lot under 18. And that's not Census 2020. That's probably American Communities Survey before that. Census 2020 is being released, little drops, and that's not there yet. So then there are not that many older adults. Most people who are immigrants, they come to work. They tend to be on the working age side. And there are older people, yes, people who have aged here, or the parents of people who have immigrated, or the people who were born in the United States and have lived here forever. There have been Latinx in Allegheny County since the 1920s at least. So not many, but some. So there is a spectrum. The majority of people are not 65 and older, and 30% are under 18.
Thank you. And Uchenna, we have a question from Dr. Christine Wilkins. What do you think about asking participants after they've participated whether they feel that the compensation was adequate relative to the burden? And then separately, a same question for asking about what kind of data they want in terms of feedback from their participation.
Yeah, that's a great question. For the first one, so I'm really pleased to see my professor, my program evaluation professor on the call, because that was where I was really crafting sort of this whole capstone topic in that class. And as I was crafting sort of the program evaluation piece of that, one thing that I crafted within there are having focus groups. So having focus groups where we focus group different stakeholders within this. So research participants, like people who are thinking about going and participating in studies, community research advisory boards, researchers, just kind of all angles of it to sort of understand it from there, so that hopefully we can gather data to really understand what are some of the bottlenecks to participation, and what are ways to kind of address those obstacles that people have who may want to participate in research studies. I know so many people who want to do it, but there's just way too much sacrifice. It's just really unreasonable and irrational in their particular circumstance to do it. So capturing that data, and like I said within my class, I would have wanted to do it through focus group to see that, and then so we can have that. And then, I'm sorry, what was the second question?
It was the same kind of question, but it was about asking what kind of data the participants might want from their presentation. So maybe sort of a little indirect to your wheelhouse, but do you have any thoughts?
What kind of data research participants would want?
What kind of information they would want back from their participation? Yep.
I mean, I think it's the biggest thing that I think we should be giving back to participants are, education. I think that's a huge resource. If they're participating in that, I think knowing, one thing that I like about the team I'm working in is always sort of that, we're coming into your community and we're getting data from you. And then once we kind of get the outcomes of that, coming and reporting back. So I think it's always the educational piece is really, really, really critical. And I believe that should be a standard piece of that. So I think it depends on the study, obviously, but the number one thing is just reporting back, engaging communities, and knowing that we're not just here to just take information from you. And then, and I liked what Dr. Thomas mentioned earlier, keep it within our scientific journals. And, you know, we have all this information and all, and it just stays there for our own prestige to be like, oh, look, I've been published in this whatever prestigious journal, but to report back and then, and even go a step further, like what was mentioned. I know Laura Ann has been doing a great job in my neighborhood here with the barbershops and the shots, but actually implementing programming and taking the next step to say, hey, we found these positive outcomes, we found this work, let's actually implement it. You know, here's the education, and we're going to take it a step further to actually implement these positive programming that we know is effective and works. So I think that that's something that would be beneficial to research participants, because they'll know that, okay, this wasn't like, you know, how many of you scientists have come here? What are you doing? What's nothing is cured? Like they actually can see something. So I think that is something that as researchers we should be taking the initiative to do.
Thank you.
Yes, I wanted to add one thing, I think, to what Uchenna said, which was really incredible. And we have a lot of resources at the university, particularly through CTSI. For instance, you know, with youth research, I've taken advantage of the Youth Research Advisory Board. They're, you know, a group of youth who come together to review researchers, you know, objectives, your aims. They ask you questions. Why are you doing this? What is it for? You know, and really to get that very critical feedback from the perspective of individuals who may not participate in your research, but can tell you, is this, you know, compensation or reimbursement or, you know, whatever the form of payment that you're offering, is it reasonable? Is it, you know, reasonable for what's being asked? So I think taking advantage of all of these infrastructures that are in place that I think often go underutilized by us as researchers are really important and can really contribute to being thoughtful about how to do this and really providing an equitable space to do it.
And also to put a plug for the Community Research Advisory Board, which is not the youth, but it was a forerunner, and Uchenna and I sit in there, and so does Mario. So that is also a resource.
That's what I was going to ask you, Patricia. I was going to ask you, I thought this was a very good note to close on, and whether there were any additional resources at the university that the researchers who are on this session should know about. So thank you all very much for sharing those resources, because we do really want to leave people with things that they can take action on that will actually help them improve their own research praxis. So thank you all for that. So I want to turn this back over to Melita to tell us what we're up to next for our break.
Wow, thank you, Uchenna. Thank you, Dr. Hill. Thank you, Dr. Documét. This has been very informative, and just want to say thank you again. I am truly excited, and I hope that from the comments, all of the attendees are excited and very appreciative of the information that is shared. We will now take a lunch break for an hour, actually 58 minutes, and we will reconvene at 1 p.m. to hear our talk from a featured speaker, Dr. Jonathan Jackson. So we would look to see you returning here at 1 p.m. Thank you.